Hello, and welcome to this episode of A Cancer Conversation with the Georgia Cancer Center at Augusta University. My name is Chris Curry, and I am your host for this podcast series. Today, we have two guests who are going to be talking about strategies to help cancer patients deal with the various painful effects of a cancer diagnosis and treatment plan. So first up, joining me, Dr. Lauren Bigham. Dr. Bigham is the director of the Georgia Cancer Center's Psychosocial Oncology program here at the Cancer Center. And joining her is Dr. Egidio Del Fabbro. Dr. Del Fabbro is a professor in the Department of Medicine at the Medical College of Georgia at Augusta University, as well as the director of Palliative Medicine here at the Cancer Center. So I want to thank both of you for joining me today for this conversation. We are going to be talking about pain. So talk to me broadly about the experience of pain in patients diagnosed with cancer.
So we know from many surveys that patients place pain or pain management as the highest priority of their multiple concerns. And I think pain or the management of pain has become all the more difficult because of the challenges with regard to medications, particularly opioids. And I think particularly in patients who have cancer, the pain is even more complex because you have a variety of different types of pain. You have neuropathic pain, you have just regular, what's called nociceptive pain. And then in addition, I think that the longitudinal, the progress of the pain is particularly challenging in patients with cancer. It can be either caused by the cancer itself, sometimes by treatments such as surgery, sometimes chemotherapy can cause neuropathy. But I think mainly the importance of pain, clearly it's foremost in patients' minds.
Yeah, and we know it certainly impacts their daily life and their quality of life. It impacts relationships, job, hobbies, interests, sleep. Mm-hmm. So not only is it a pretty crummy physical experience, but it has a lot of kind of secondary impacts that also cause a great deal of emotional, social kind of distress as well. But I'm looking forward to talking more about how we can manage many of these impacts.
What are your goals when working with patients who have pain, who come to you and they're complaining of this or that, this hurts, that hurts? Kind of what are your goals when working with these patients?
I think and you and I might have slightly different goals. So for me, it's how do we find a way to manage the pain and the secondary impacts of pain. What would you say your goals fundamentally are when you first work with these patients?
I think ultimately we want to improve function because typically pain results in a decrease in function. And as you pointed out, in addition to the important physical function that is affected, we have psychological functioning, intellectual functioning. I think, as you point out, I think your cognitive function is going to be affected significantly when constantly you have this intrusive, severe, agonizing pain. So I think, yes, we take a different approach to pain management, but it's essential to have this interdisciplinary team in order to achieve, both those goals.
For sure. So not only kind of the management of the pain, but improvement in functioning and then improvement in quality of life. And there's so many ways that we get at that. Where do you first start?
I suppose it would be asking about the pain, trying to identify what kind of pain it is, because that would influence which medications I might choose. And I suppose I'd be responsible in many ways for the medications, choosing them correctly, correct dose, reassuring patients who often come in who may be to some degree opioid phobic, that there's been so much in the news that the pendulum has swung over to the other side, that patients are now reluctant perhaps to start opioids. And of course we recognize that opioids shouldn't be given if they don't need to be, but that's where I start trying to identify the type of pain, how it's affecting their function, and also perhaps other symptoms. If patients are already coming in on pain medication, I definitely ask about drowsiness, difficulty in thinking clearly, because deprescribing is another function, important function of mine.
Yeah, and looking at kind of the secondary impact. So when we think about pain medicines, they certainly in themselves have risks. They have impacts, cognitive functioning, fatigue. So I really appreciate you looking at that kind of entire constellation. And I also really appreciate you mentioning the beliefs. So Chris, many of our patients come in and they get really, I don't want to be dependent. I don't want to be hooked. I don't want to have a problem. Or they'll come in with this belief: don't mess with my pain meds. Or the belief is I can't handle it without them. I can't manage the pain and the discomfort without this particular cocktail. And so there's some beliefs that can be really tricky as we work with our patient.
What are some conversations? Even, Dr. Del Fabbro talked about the buzz around opioids in general. What kind of conversations are you having with your patients who have those beliefs or have those concerns about opioids? What are you saying to them? How are you trying to get them to understand and sort of accept your word and your expertise? Because I imagine that doing so, building that trust, is going to mean a lot in the treatment of pain.
I think establishing a rapport with the patient first and foremost, and really hearing them out. Where are they coming from? What are they thinking? How do they understand this? Sometimes they have family or friends who've had bad experiences, or listening to their personal experiences then leads us down a path where we can, okay, so you understand this medicine like this, okay. I wonder if I could give you some more information about this medicine, or, if we could look at this belief a little bit more. That's how I go about it. But I'm also not the prescriber.
So I reassure them that at some point, or at varying recurrent points in our visits, we're going to determine whether opioids are still necessary, whether we can reduce the dose, and perhaps they've had tremendous benefit from visiting you or your group, and we can actually reduce the dose of opioids. Perhaps a treatment has been so successful that they no longer require opioids, and we're constantly evaluating function versus opioid dose. So I try to reassure them that this is not set in stone, that once we prescribe an opioid, it doesn't mean that we're going to progressively escalate doses. I also reassure them that if we get to higher doses, we have strategies to overcome a further escalation. And sometimes it's as simple as switching to another opioid.
Okay.
And I really appreciate that, because here we try to offer really patient-centered care, to hear where they're coming from, and then to tailor their treatment to really improve their experience of pain and their quality of life. And I think that's why it's so nice to have psychology and palliative to optimize one another. I think for palliative, especially for many of our patients, I'm thrilled to educate on palliative, because you all do such a nice job with reducing the burden of our cancer care and allowing our patients to live a full life. And in that way, we're very much aligned. So having kind of both of us in the pot together is always quite nice.
Yes. And I mean, there is an overlap in the way pain is perceived at a central level, that the social pain area kind of overlaps with the physical pain. So treating one of those types of pain in isolation isn't going to work. it's a good idea to have a combined effort, obviously, and I think we're so much more successful as a result.
I agree. And you know what causes a great deal of physical pain is anxiety. And sometimes people experience anxiety as physical pain or discomfort. And so having a good idea of kind of what is this pain and where is it in fact coming from or what's making it worse. Chris, I feel like we went off topic.
No, it's fine. This is a conversation designed to educate and share lots of information and lots of insight. So going a little bit off topic is perfectly fine. Talk about each of you talk a little bit about your foundation for effective pain management. What is like a person who comes in complaining of pain, having pain, what is like the very beginning thought for how they're going to be able to manage their pain working with each of you?
I want them to come in, or my hope would be that they've observed their pain and we can just talk through the specifics of their pain. Is it new pain? Is it old pain? Where is the pain originating from? What worsens their pain? What makes their pain better? What have they tried? What did not work? What worked a little? Anything else that I'm missing?
Yeah, the way I approach it is to identify factors, as you mentioned, where I need help. And one of those factors might be a history of depression or anxiety, where pain expression might be amplified without the patient really knowing often that they are suffering from or have a history of depressed mood, history of anxiety. So those patients would definitely benefit from your expertise. At times, of course, I prescribe medications, and as it happens, there is a medication, duloxetine. Mention no trade names, but duloxetine does treat both. And again, confirming or supporting that notion that maybe pain is multidimensional, psychological, as well as physical. And the other thing I do is, of course, screen for patients who have had difficulties in the past, maybe with alcohol use or drug use, and realize that this is going to be a challenge for them. Some patients come to me and volunteer that they've had difficulty with either alcohol or opioids in the past and are reluctant to start specifically for that reason. And then, all the other factors that are related either to perhaps the cancer, whether it's metastasized in an area that's particularly painful. So these are the kind of factors that I try to identify that may be increasing pain perception, but also increasing the expression of pain. And, not only your wonderful service, but also they may require physical therapy if they've had post-mastectomy pain, post-surgical pain. So one of my other colleagues may be helpful in managing a patient, filling the gaps that I can't fill.
And sometimes the pain itself, there's another belief about pain. If I sit still or if I don't do too much, maybe my pain will improve. But then we have tension in the body, we have deconditioning in the body, which actually can worsen pain over time. And so I really appreciate you mentioning physical therapy, PT, occupational therapy can be really helpful. Lymphedema care, which we have here at our cancer center to help with the experience of pain. And so looking at the kind of the entirety, there's also this line of research that suggests unmanaged depression makes your pain worse. And unmanaged pain makes your depression worse.
Okay.
The same with anxiety too. So making sure that we're addressing all of the elements that contribute to our experience of pain can be really helpful. I also like that medication that you mentioned because it helps with both depression, anxiety, and pain.
Yeah.
And it seems very helpful.
Yeah, and we reduce the polypharmacy, having one medication that might improve two symptoms, two conditions, is always useful. But I'm also glad you mentioned perhaps theories of managing pain or managing fatigue that are no longer applicable, or research has told us that perhaps we should have patients be more active, both for fatigue but also for pain. There's been a few studies now to suggest that neuropathic pain, whether it be related, for example, to chemotherapy, can be improved with physical exercise, brisk walking, for example. So those kind of misconceptions, really from the past, where we used to tell patients not to move a whole lot, to rest, to restore the energy. Now, sometimes that may be applicable, but for the most part, it's better to move.
It is. I agree. I often tell them the talk test. If you can walk and talk and still be a little breathy, you're right where you need to be. But if you can't talk while you're walking, maybe a little too much. But I'm always so astounded because, it is the first instinct, especially when you're kids. If you're in pain, you don't move. Or maybe if we can sleep it off, it will be better. But that's not necessarily that's not kind of how it's holding true these days. It's like Alice in Wonderland. What's up is down and down is up.
And I want to ask too, you mentioned the development of this medication that can treat anxiety, depression, pain. Do we see that being the future? Because I think about even what we find over the counter, your Advils, your Aleve, your aspirins, your Tylenols, your Motrin, all of your medications that are designed to help with some different types of pain. But do we see more medications in the future that are designed to attack multiple symptoms instead of just the pain itself? What do you see in the research? What are you hearing? What are you reading?
So I think to bringing some oldies but goodies forward. So I think the future is going to involve a lot more holistic pain management and comprehensive pain management. There are things that we don't really understand, or we haven't understand, that maybe we're having better understanding with now. Acupuncture, light movement, certainly heat and some kinds of pains is helpful, cold compresses and other types. So having kind of more a robust pain management, kind of as opposed to just medicine, maybe. Is that answering that question? Yeah. What are your thoughts?
Yeah, I think it's true that we should move beyond medication, because I think it would be wonderful, but it might be challenging to develop that medication that takes away the psychological and physical pain, takes away the total pain, also the existential suffering. Total pain was a term coined by our founder, Cicely Saunders, and I think is a great one. It would be wonderful if they could develop a drug, and some drugs, as I mentioned, do both treat physical pain as well as psychological, but I do think that it's probably going to require a combination of pharmacological and non-pharmacological therapies, including exercise, psychotherapy, and maybe acupuncture to manage pain effectively. I think some of the old medications that you described, the non-steroidal anti-inflammatories, they're great medications and may be particularly useful, for example, for bone pain, but have the potential for side effects, particularly in patients with cancer, and may affect things like clotting and bleeding, for example.
Okay. Let's talk about the gait control theory of pain. How does this help guide treatment options and planning when it comes to pain management?
Yeah, the gait theory for pain suggests that we have these small fibers that carry impulses of pain, particularly burning sensations, pain sensations, carry them all the way to the spine and then up to our brain. And the gait control theory suggests that if we had other interfering impulses or sensations that, for example, weren't painful, that this would close that gait or disrupt the flow of pain impulses. And, whether it be light rubbing, whether it be non-physical input, endorphins for some reason, including exercise, for example, this could disrupt the flow of pain through these small diameter fibers. So that's the way I understand, and definitely non-pharmacological therapy is crucial here. There are some drugs that might help, but again, I think this is going to be the cornerstone. Once we use medications such as opioids, we're going to need to augment that with non-pharmacological treatment.
Yeah, and I think for everybody it's going to look different. So once you go through and kind of work towards a nice management with medications, looking at the other things that might close that gate of those pain signals being translated and experienced in the brain. One that just came to my mind while you were talking about it, and you had such a nice description, a TENS unit.
Yes.
I find that with many of our patients, TENS units help disrupt that flow of that kind of fibrous message and almost distract the brain a little bit. Are you familiar with the TENS unit, Chris?
I was going to ask you to talk a little bit more about what that is.
Oh gosh, maybe I should defer to you. What do you think?
Yes, and I don't use TENS units myself, but yes, the stimulation of nerves in a non-painful manner sends impulses, and they send impulses through these larger fiber nerves that close the gate and stop this painful impulse from traveling all the way through. And, perhaps, and again, I don't perform acupuncture, but as you mentioned, is a pretty useful modality sometimes and may also work in a similar fashion in closing that gate.
Yeah, osteopathic manipulation is another to consider.
What is that?
It's certain manipulations, kind of like chiropractics, manipulations of the body that allow for kind of release of tension or helping to recalibrate. That can help with pain or at least tension at times.
Okay.
So between TENS units or acupuncture or osteopathy or chiropractics, heat, massage. I wish we could prescribe more massage around here. But
Yeah, and massage therapy happened to be the most popular intervention at one of my prior institutions.
Really?
Yeah. So it was more popular than all of the others.
I'm sure it was.
Yes.
How did this happen?
It's a shame. Particularly was delivered in the palliative care unit in the inpatient setting. But yes, I'm sure that would be a popular intervention. It's been shown to be effective as well.
Especially among providers, family,
Yes.
patients, everybody.
Yeah.
So there's many ways to manage the experience of pain. Aquatherapy is one that I find that, but for many of these things, like a TENS unit, you'd go to a physical therapist for. Aquatherapy, physical therapy, acupuncture, you go to somebody who's certified in acupuncture. So again, it takes a team to kind of, or we bring a team in, and we're hoping to kind of build more in those ways here at our cancer center. Tai Chi has also been kind of another alternative kind of light physical activity that can help with pain. But these are all things that, for many, they don't even realize that they might help close that gate and reduce the suffering from pain. To kind of follow back up on your question about that gate control theory of pain.
We're talking about palliative medicine. These are people who are maybe further along in their cancer experience, but are still trying to live the most life that they can live the best way that they can. So there's probably a caregiver of some sort involved. And, when we talked to you before, Dr. Bigham, we talked about caregiver support is something that your team also offers. So what role does a caregiver play in pain management?
I know that in the room with the patient and the caregiver, I usually get a very honest response from the caregiver.
Yeah, I mean, a collateral history
can be very helpful.
from the caregiver is essential, and It's sometimes also very useful in that the caregiver might identify the patient having severe pain, but again, for a variety of reasons, perhaps not wanting to start on opioids, perhaps wanting to just tough it out, wanting not to exhibit advanced illness. For a variety of reasons, the patient may not volunteer that they're in severe pain. And so you get this from the caregiver. You may also get from the caregiver the opposite, the caregiver identifying that perhaps the patient is not using the opioid medication exclusively for pain management, but for other reasons. Collaborating with caregiver, patient, I think, is essential, just also to ensure that medications are taken correctly. I find it difficult to take one tablet a day, one capsule a day. I can't imagine how challenging it is to take multiple medications. So for a variety of reasons, and then of course the burnout of caregivers. They accompany patients to clinic visits, hospital visits, a variety of visits. So again, it is essential. I think that we see them as a unit. And of course, we have our colleagues here who can address some of the burnout, perhaps, suffered by caregivers.
It's very hard to see a family member in pain. It's very, very hard day after day to see, especially when it's unmanaged. And that puts a lot of strain on relationships. And you really want to keep your caregivers as strong as you want to keep your patient strong. Caregivers also really helpful. I agree with you, especially on the management of medicines. Sometimes when somebody is in so much pain, they forget that they've taken something. And maybe I've had many caregivers step in and really reduce the amount of kind of medication confusion, because that can be a really common and easy mistake to make if you're kind of sleepy or tired and you're in a lot of pain, and next thing you know, you've taken maybe a little bit too much. The value of our caregivers is just, I'm not sure I can emphasize it enough. But also in the work that we do, having opportunity to support communication between caregiver and patient in a way that feels heard, informed, listened to, respectful, and assertive, I think really can also help alleviate stress. And that also can, when we reduce the experience of stress, we can actually reduce the experience of physical pain. So oftentimes if I see maybe a dynamic happening in the room that might be very stressful, that certainly would be worth a referral or more conversation about maybe what psychology can do in helping that dynamic kind of communicate, strengthen, and de-stress a little bit.
Does a referral for palliative medicine, psychosocial oncology care, does it originate with that primary oncologist, or do they come to you, Dr. Bigham, and then you refer them to Dr. Del Fabbro, or Dr. Del Fabbro, do they start with you, and do you then refer them to Dr. Bigham? What does that sort of process look like? So I'm thinking if I'm a cancer patient at the cancer center or coming to the cancer center and I'm worried about pain, what are sort of my options to be able to work with y'all on my pain management?
Yeah, that's a great question. And I think we get our referrals from a variety of sources and ways. And you're correct that maybe a predominant source are oncologists, and the medical oncologists, as well as the surgeons, by the way, refer to us. We also get many from Dr. Bigham, and I'm sure I send Dr. Bigham a fair number of patients. We also get patients who are discharged from the inpatient setting and then follow up with us in the outpatient clinic. I think the patients should ask their oncologists for a referral. They can certainly contact us directly, but usually they've got a lot to think about, a lot to discuss during a medical oncology visit, but perhaps at the end, if they were asked to be referred to the supportive care clinic or palliative medicine physician, because I work in the supportive care clinic, and that's to signify perhaps that we manage patients not only at the end of life, but also at the beginning of diagnosis, and for those patients who are being treated with a curative intent, they are also very appropriate for palliative care, particularly if they have symptoms that are uncontrolled, such as pain.
And I think a lot of people don't realize that that is certainly a very important element of their treatment plan. And, you know, at kind of larger cancer centers, you get your medical oncologist, and then you start care with a palliative medicine team. And your medical oncologist takes care of the chemo, and your palliative medicine team takes care of everything else under the sun, which we appreciate, all the way from pain to neuropathy, another form of pain. I really appreciate when I get to refer patients over to you for especially things like sleep, anxiety, and depression, constipation and diarrhea. Thank you for all. That makes somebody very miserable.
Sure, it does.
No, that makes pain even worse, doesn't it? You know, what other symptom burden does palliative care for in addition?
Yeah, well, the constipation is actually a good one, because in our experience, that's probably the most troublesome symptom related to opioids. I know there are some very serious issues, of course, addiction we are well aware of, but the one we find that is most common, most troublesome, is constipation. And then, as you point out, mood, anxiety, fatigue is another, which I think takes a multidisciplinary approach, and for which there is no single specific intervention. We are doing a trial here that is sponsored by the NIH to look at improving perhaps fatigue in men. We'll start small and then expand. And then, the other symptoms such as sleeplessness and shortness of breath. So those are usually the...
Appetite.
Appetite is another major one. Thanks for reminding me.
Yeah, no problem.
And that again, because there is no single medication without side effects, it again takes a multidisciplinary approach, dietitians and, of course, psychotherapy as well, and reframing the conscious control of eating. Am I borrowing from you?
Yes, that's fine. Please borrow away. Nice job.
Sure.
There's many ways to find us. And then I think what's nice is that if I'm in an appointment with a patient and I can tell that our pain is unmanaged, or our constipation is making life miserable, or we're not eating and we're fatigued and we're getting deconditioned, to then help that patient get to palliative, to help that patient get to the dietitians. I know that you commonly refer out to physical therapy too. I think I've seen that in the notes a fair amount.
Yes.
So however they find one of us or both of us, we'll help them get connected to wherever else they need to get to. I think that's the most important part. It doesn't just end with your medical oncologist. Your medical oncologist is very important, and your surgical oncologist. We work really closely with them, but there is usually a much broader team behind them.
So talk to me about how someone can get the most from their pain medication.
Yeah, I think the key is to take the medication as prescribed, to take the medication on time. If it's prescribed twice a day, particularly an extended release opioid, that it should be taken twice a day. And that if it was an immediate release opioid, to take it as needed, with the prescribed intervals between doses, so not to increase the dose, not to take it earlier. And I think crucially is to be sure it's locked up in a safe place. That is absolutely essential. We know that most people who develop a substance use disorder started off by using prescribed medications, and typically they've obtained it from a family member or a friend. So locking it up in a safe place, I think, is crucial, and not to self-escalate the dose.
I try to tell people, if you feel like your pain has improved, that's a good thing, but keep on the same regimen. Don't try to skip doses, or when we get ahead of our pain, that's when we experience improvement in our pain. But it's very hard to get caught back up when we get behind the pain. And I know it can be tricky to keep track of how much you have at home, but making sure you call ahead and when you need refills and things of the sort. Sometimes I know people get in binds and maybe will share with family.
I imagine that's a very bad idea.
Yes. Yeah, it can get a little tricky. And always starts with good intention, but it might be expired, or it might not be the right dose or the right medicine. It could have interactions. So trying to kind of limit the confusion, stay on what they prescribed at the intervals that they prescribed it. And if it doesn't work, it's okay to go back to your doctor and say, gee whiz, this just quite isn't working. What do you think? And then that means that we need something different. Mm-hmm. And have a conversation about it. Or if they're too sleepy, go back to your doctor and say, I'm a little too sleepy. Let's do something different here. It's all about being able to go back to the doctor and have more conversations about tailoring things in to where they can optimally kind of help that person.
Which goes all the way back to what we started talking about in the very beginning with like building that trust, because you have to tell them what to do and how to do it and when to do it, and they have to trust you and they have to believe you because of all the word out there about opioids and other prescription medications. So
yeah, and we want them to come back and tell us if it doesn't work.
Yeah, or if it's working so well that they can reduce the dose. Brilliant.
Fabulous.
Wonderful news.
Everybody deserves a gold star for that day, but as long as we're getting them in the right direction and being open to some of the other kind of complementary ways that we can manage pain.
I want to thank you both for taking the time to speak with me today, be part of this discussion. I feel like we've covered a lot, and I hope that it will be very informative and helpful to those who find this episode, watch it, listen to it. So thank you both for joining me today and for being here. I appreciate it.
Thanks for having us.
Absolutely. And thank you for watching and listening to A Cancer Conversation with the Georgia Cancer Center. You can find us on any of the main podcast networks: Apple, Google, Amazon, YouTube. Just search Georgia Cancer Center or A Cancer Conversation. And remember, if you have questions or topics that you would like us to talk about and to get information for, you can always send us an email. It's cancer@augusta.edu, and we'd be happy to schedule those conversations, whether it's bringing Dr. Bigham and Dr. Del Fabbro back for even more conversation, or any of the other experts here at the Cancer Center. So thank you for watching, thank you for listening, and thank you for subscribing.